isn't it? You get her out of trouble and she always found her way back in.
Hello, good afternoon, and thank you all for joining us today. We will give it about a minute for others in the lobby to get admitted in before we go ahead and get started. However, while we wait, if you are just joining us and you are off mute, we ask that you put yourself on mute. That way, your audio does not disrupt the conversations. Thank you.
My job to use you, just like it's your job to be of use. Did you accomplish?
Awesome. And let's see here. I will go ahead and mute everyone to ensure that we can all stay on mute. Okay, it is 4:31 and we will get this started. Thank you once again for joining us today. My name is Brutus Shigan, and I am here as the project manager helping drive the implementation of some of the projects on that KDADS IDD Modernization program, specifically the MFEI projects, and that would be the key focus of our conversation today. We welcome you to this month's webinar, and shortly I will be passing it on to Assistant Commissioner Seth Gilbert to kick us off with the conversation that we have that we're going to be having today. Overall, while that is happening, we ask that you remain on mute. If you have questions, feel free to utilize the chat functionality here, or raise your hand so we can call onto you to ask your questions once we open it up for questions. And with that said, I will go ahead and pass it on to Seth to start the webinar today. Thank you, Seth.
Thank you, Brutus. Good afternoon, everyone. Thank you all for being here. Like Brutus said, my name's Seth Gilbert. I'm the Assistant Commissioner for the Long-Term Services and Sports Commission here at KDADS. And so this is one of our monthly webinars for the month of May on hoping to provide some updates on the MFEI implementation. So here's just a brief agenda. I'm going to go over some of the modernization program projects and health timeline, and then introduce what we've got as far as a MFEI IDD bridge policy for those individuals who will be newly coming on to the waiver. And then we'll have some, hopefully a good amount of time for questions for y'all to ask and some closing remarks. So projects currently underway under our IDD modernization efforts. First one, the MFEI, we're still currently on track for a July 1st, 2025 go live date. That we're still looking in pretty good shape for that. Unbundling of day services, that is still something that's in progress, but we're still tracking for a July 1 of 2026. Conflict-free case management, that one is still in the works. We're currently developing based on some recommendations from a stakeholder group, looking at feasibility and things of that nature. So we hope to have something come out here in the next several weeks related to a roadmap. potential path forward on resolving conflict-free case management. And this is really key as it is critical for our community sports waiver that is still in development. We are hoping to have that submitted to CMS late this fall. They need a full 6-month window to review it. So we are, in development of the various waiver appendixes, and hope to have that ready to go and serving people late spring, early or midsummer of next year as well. And then we've also got grant opportunities through ARPA that I think we've put out New Day grants, some conflict-free grants, and then there's also been some HCB provider expansion grants. Those opportunities have been closed, so we don't have any current open funding opportunities related to that. However, for those organizations who have applied, be on the lookout for more information as we are currently making awards and finishing up the review of those grants. So to kind of dive right in here, if you all remember, there's for existing participants who have a current tier score, meaning they've been served on the waiver before July 1. Nothing is changing about their tier score. This bridge policy, just to, I'll reiterate this several times, this is really only hitting on new participants to the waiver. So folks who are maybe on the wait list right now, or on another waiver, have yet to transition to the IDD waiver after July 1 of 2025. So we will be implementing a temporary bridge payment policy for these individuals when they come onto the IDD waiver, in alignment with recommendations that were made by an MFEI funding subgroup that met through March and April, and I think wrapped up early in May. So this subgroup comprised of representatives from community developmental disability organizations, CDDOs. We had representatives from community service providers, MCOs, and other stakeholders and family members that met over the span of, like I said, 6 weeks to evaluate funding implications for the MFEI implementation and to develop a short-term strategy that ensures continuity and equity during this transition. So give a high-level overview of the policy timeline. Like I said, once we go live on July 1st of 2025, that is when this bridge policy rate will begin for these new members only. Again, this is because everybody come July 1 on the IDD waiver, whether it's an initial assessment or an annual reassessment, will have the MFEI be that assessment. So this bridge policy is encompassing those folks who are going to be new on the waiver. It will end on June 30th of 2026, so it is very time limited. And once we go live, we will be pivoting to a new mechanism or new reimbursement policy that will be based on MFEI and or NRRAI data. So to give you a little bit of background on how the rates were developed, this was done through data-driven process. Because this isn't taking any money out of the system, it's not saving the state any money. It also couldn't cost the state any money. So we really had to focus on a rate that would be cost neutral. And so the starting point was the average reimbursement rates paid to day and residential providers for individuals that were newly enrolled in the waiver during state fiscal year 2024. So we went back an entire fiscal year and looked at all of those folks who came onto the waiver during that year and looked at what their rates on average were being paid for those day and residential services. However, to reflect the upcoming budget changes, we've also included that approved rate increase. The IDD rates got a 1.5% increase for state fiscal year 2025. So if you weren't aware, hopefully you are now, that is coming down the pike as well. And so we want to make sure that the proposed rate will also include is also baking in that 1.5% increase. So the end result is a standardized rate that is designed to be cost neutral, again, like I said, and hopefully cause as minimal disruption for providers while supporting continuity of care for participants who are served by the IDD waiver. So we just, again, really wanted to ensure that the temporary bridge rate was grounded in, real world data and reflects our current fiscal policy, the constraint around needing this to be fiscally neutral and provide a reliable foundation during the transition period. We'll touch on this a little bit later, but extraordinary funding will continue to be an option for all waiver participants who are in a day of residential service, regardless if you are in a legacy rate or you are a legacy tiered rate or under this new bridge policy rate. We've kind of hit on this before, but the bridge policy here was developed and, like I said, in collaboration with stakeholders and those who are really familiar with the system. The goals, again, ensuring continuity. We want to make sure that we can go live with the MFEI while also orienting ourselves towards something that's going to be a lot more sustainable and mapped more so to a person's actual support needs. We hope that it's going to provide a predictable and transparent reimbursement for providers while we, look at those various models that are going to be under development and in conjunction with stakeholders from the system. And then we wanted to be able to create a space for meaningful data collection and analysis. So again, this is all about how can we make sure that the assessment is accurately capturing the support needs, and then a funding mechanism is appropriately mapped to those support needs so that it is sustainable for all everyone involved, whether that's a provider, family member, person being served, everybody involved. And finally, we want to make sure that we're honoring the input of all of those key stakeholders as well: CDDOs, MCOs, family members, person served, by reflecting those recommendations in the transition strategy and policy design. So as I mentioned earlier, we are still going to have extraordinary funding, and we are still working and having discussions internally on how we can streamline that extraordinary funding process so that providers who are serving individuals with those complex medical or behavioral support needs are still going to be able to request an enhanced reimbursement by submitting an EF request through the participant's MCO. And those requests are still going to follow the KDADS extraordinary funding policy, which, like I said, we recognize there's some gaps and some, it's due for a refresh, to put it mildly, and we're going to get that underway, and it's currently under revision, and so we hope to have that out here soon as well. And as mentioned earlier, this bridge policy will expire on June 30th of 26, and that new permanent rate structure will take effect for all HCBS IDD participants thereafter. And we're going to be beginning that work once we go live with the MFEI, and so we're going to need a lot of participation from people in the system on feedback there. So to kind of give a high level overview of what this does to the overall workflow, not a lot's going to be changing. If you're somebody new on July 1st coming into the system, you are going to have that CDDO functional eligibility who conducts the MFEI. KDADS, the MFEI being a KDADS program, is what determines that eligibility score. Even though that MFEI is done by the CDDO, the score is ultimately owned by KDADS, and we're the ones who make that final determination of yes, this person is eligible for the waiver. At that point, it will still go to the MCO and the TCM to coordinate the person-centered services and support planning. And the MCOs are still on track to go live with using the Inter-RAI service planning instruments in that service planning process. And that is what informs what services somebody will want, what their goals are, how to make those goals and those services work together to meet the person's needs and their preferred lifestyle. And then that is where HCBS IDD waiver services and the actual service providers step in to kind of make the magic happen. So talking about some of the pros for families and participants here, the one of the key things is that there's really going to be no disruption in services. So this is ensuring that newly enrolled participants can begin those services on time without delays caused by any rate structure uncertainties during the MFEI rollout. We know there was some stuff that was floated early on, and we've heard you loud and clear, and so we really wanted to make this as simple as possible. But this also allows for a pathway to long-term improvements. So, the MFEI is much more robust data, and it allows the state in conjunction with others to make those informed decisions that will hopefully lead to more sustainable person-centered funding model in the future. And it's also built-in flexibility for complex needs. So for those individuals for who that higher support need is still in existence, and the rate maybe is not fully covering it, providers are still going to be able to request that additional funding through the extraordinary funding or EF process. We want to ensure that care is tailored to individual needs, even with a standard floor rate structure. And then finally, we want to ensure that stakeholders feel included in the process, that this is reflective of recommendations from a strong stakeholder group that included those CSPs, MCOs, and CDDOs. All right. Key dates. So May 29th, that's today. It's CDDO assessors who have not completed training. You're gonna start getting some prompts and messages from KDADS, and just want to ensure that we get everybody trained, even though we know there's still some tweaks we have to make to the training program. But then on June 23rd, we will open up the application for CDDOs to begin accessing it and able to download the offline versions on their systems and in their computers. And then come on July 1st, MFEI will go live for all IDD assessments. And then at the same time, that is when the bridge policy will start for any new waiver participant. So anyone else who is currently in the existing system, they will still have their same tier score with that 1.5% increase to go along with it. Just to hopefully drive this home, just a little bit of a hypothetical here. If we've got a person, say Maria, who is starting her first coming onto the waiver, let's say she's newly enrolled on the waiver on, July 5th, 2025, because we have people coming on at all, not just during waitlist, but offers, but also through crisis, exception, transitions. There's a wide variety of ways people can access the IDD waiver. And so if we say she lives at home with her family, but has the MFEI, she's eligible, and goes into the person-centered service and support plan meeting and would like to have supports and day services or day habilitation to build some of those independent living skills and maybe eventually transition to part-time employment. So the MCO is going to go ahead and authorize day supports. And when she goes, the rate for that will be, because she's new, will be the new single rate structure under this bridge policy. And so her provider will bill day habilitation using the code T2021UB. Anyone else under the legacy rate system will just have T2021. However, because her needs are moderate and aligned with service use, the standardized rate provides a smooth and timely start to services with no disruption. So the provider's looking at her support needs, saying, hey, yes, this rate is sufficient. We can just we can start, and let's meet her needs and get some of these goals met. So if we tweak this scenario slightly, this time we've got David, a young man, age 28. He is also joining the waiver shortly after we go live with the MFEI and has potentially been discharged from a long-term care hospital. So right off the bat, you're going, this is somebody who's coming out of a long-term care hospital. I think it's a reasonable assumption that they probably have some fairly high needs. And through the service planning is wanting to go into a residential service provider, because it's been identified that he does need 24-hour residential supports with some nursing oversight. Maybe there's some behavioral health needs and a little bit more one-on-one support related to customized routines and things of that nature. So this individual, David, would bill, the provider would bill under T2016 UB. Again, you see that modifier UB for those new individuals for residential services. However, because of his more complex needs, his provider might say to the MCO, this rate is not quite sufficient. We would like to go ahead and request extraordinary funding. The bridge policy ensures that a process is in place for the MCO and the provider to layer in additional funding that will support timely service delivery under the standardized model. So that's concluding the presentation portion. Right now, I know a lot of you are looking for what the actual rates are for each one of these services. We don't have that right now to share as we are working through the policy process on our end with KDHE and MCO. So we don't have kind of the final stamp of approval, but there will be a provider bulletin that is released through KMAP when that's ready to go live here in a couple weeks. So you'll be able to see that at that time. And we might even be able to communicate it out sooner. However, don't have it to share right at this time. But I will pause there, and I think we're ready to go ahead and maybe open it up for questions.
And I think Cami has a hand up. Cami, do you want to go ahead and ask your question, please?
Thank you, Brutus. I have a question about extraordinary funding. How long does that application process take, and how are that person's services paid for while they're waiting for the extraordinary funds to come through?
Ooh. Yeah, I'm not well versed on extraordinary funding, Cami. I would probably phone a friend for one of my colleagues to maybe step in and answer that. Robin, are you available?
Is that me? Is that the
Yes.
phone a friend? I don't know if you picked the right one, but I do have some experience in EF, but it's been quite a few years, and yeah, we're looking at the policy. It can vary a little bit. I mean, there's initial requests, which can be more lengthy, and because the MCO is really trying to, well, the provider has to gather a bunch of information and then submit it to the MCO. The MCO reviews it. The MCO might have, since it's a new request, they might have follow-up questions and things of that nature. So there might be a little bit of back and forth on that. And then, but then there's also renewals. And so one of the things we're looking for is reducing the renewal rate. So currently it's annual for each EF request, and we're hoping to get it to where it's every other year for those that just request standard EF as opposed to an individualized rate. It just depends. I don't know. I'm trying to think. It's been a few years. I mean, it's not overnight by any means, but I mean, I want to say a month, but I don't want to be held to that either. There's timelines written out in the policy, which I don't have that in front of me. It's like the MCO has X amount of days to review and get back to the person, and then if it's sent back, the provider has X amount of days to respond or provide additional information and just stuff like that. And I think the MCOs have like an EF committee that they utilize internally as well. And so anyway, I hope that's helpful. I know it's not a very clear answer that you might like, but
yeah, Robin, thank you for doing your best. I know that's something that has really been concerning to parents and guardians and family members about this, having to appeal to the MCO for extraordinary funding. And again, so however long that it takes to approve it, how are those needed services paid for in the interim?
trying to remember. So I shouldn't say a lot of times, because I don't know the statistics on it, but sometimes, the provider will be serving the person for a while, and they've got the reimbursed rate that's established per the level of care assessment. And then maybe there's a life event that happens, right? And so if a life event happens, then they would go through that process. And in the meantime, they would continue to get the rate that was established due to the, the level of care assessment. Sometimes I think there's certain graces that can be allowed, like certain discharges, like from institutions and things like that. They know it's going to be a case that needs more support. So there's some flexibility there, I believe. So again, it kind of depends on the scenario, but a lot of times it is established initially by the rate that's established by the level of care assessment.
So, I mean, in the scenario that Seth just reviewed, this person who is high need and just being discharged from a hospital and is coming in new. So in that kind of a scenario, does that help give some of the qualifiers on it? I mean, this is a person who's not received services before. So, and I guess part of what I'm hearing you saying is that then the provider just has to cover it in the interim, and then do they get reimbursed for any extra expenses beyond? I'm just curious about the whole process. And maybe this is something that that LTSS staff can explore further and answer this question more thoroughly.
Yeah,
Well, I mean,
Cami,
go ahead, Seth.
well, I was just gonna say, you know, that in that instance, you know, you'll have the MFEI done, so you know, the CDDO, and the MCO will be able to see what those support needs are based on the MFEI. So there should be a pretty good idea, right? You know, once you've done that MFEI, to be like, ooh, you know, a decent ballpark, you know, figure on you know, we don't know if this would be sufficient. So at that time, then you know, the expectation would be that the CDDO, the MCOs are kind of thinking through who would be a good fit, you know, to be able to serve this person, and you know, there's choice and options counseling, and all of that happens. But yeah, there's a lot of those conversations happen in preparation for what that individual is ultimately driving towards. But you know, that's again the promise of the MFEI, is that you get a much more holistic picture of a person's support needs, and so you're going to have a much better idea once that assessment is completed as to whether that person may or may not actually even need it from the outset.
All right, thank you.
And we have Shaylee. Can you please come off mute and ask your question? Oh, you are on mute, Shaylee, so we might. Yes,
Oh,
there we go.
you can hear me now. Okay,
Yes.
thank you. Thanks, Brutus, for calling on me. I'm Shelley Harrington from Sedgwick County. Seth, this question is for you. So I hear you calling the MEFI rate situation a bridge policy. So is this a policy in terms of an actual policy? And is this going to be released to the CDDOs per our contract, or how is that going to be addressed?
No, it's not a provider or front-facing policy. You know, we have to
Okay.
go through Medicaid rate, Department of Healthcare Finance on anything that touches rates, and so KDHE considers this a policy from that standpoint. So yeah, there's some borrowing of terms.
Okay, so it's not a policy, but we're calling it a policy.
It's a can-care policy for healthcare finance.
Yeah.
Okay, I'm not sure who responded to that. Didn't sound like Seth.
That was Deputy Secretary Brown, but yeah, it's
Okay.
for KDHE's purposes, this is considered a policy. For CDDO purposes, probably more of a procedural technical change.
Thank you for clarifying.
And calling on Cami, please come off mute and ask your question.
Thank you, Brutus. I've heard it said several times now that, and maybe I'm just confused, which is altogether possible, that this new plan is not going to save the state or cost the state. However, I know that lots and lots of dollars have been poured into contractors and subcontractors and for-profit consultants and not-for-profit consultants. Is all of that being paid for through American Rescue Funds? Because that's a lot of dollars, so that's not costing the state then per se?
No, Cami, there's two broad buckets. You know, we've got our services bucket, and that's where we draw down FFP or federal financial participation, where the state puts up, you know, roughly 40%, the federal government covers 60% of the services. And then there's a Medicaid administrative bucket. And so that is one where basically encompasses anything that that would require the state to, help us essentially administer the Medicaid HCBS program. So when we say that this is not costing the state any money, it's not costing us anything out of that services bucket.
Okay, the services back. So administrative, so PCG and charting the life course and all of those are being paid for out of this administrative bucket and or American Rescue.
Right.
Okay, thank you.
And we have David. Please come off mute and ask your question, sir.
Yeah, so following the completion of the MFEI, when are providers, case managers, MCOs going to actually see these inter-RAI tools that are supposed to be used for service planning that's going into effect, in a month?
So the tools themselves, we're unable to share per our licensing agreement with Inter-RAI. However, the service plan, which the tools feed into that service plan, you will still receive that as part of the kind of the standard process. When the MCO completes it or at the time of signature, you'll be able to see those what the actual service plan is looking like.
So we can't see the tool that was used to develop the plan, but we can see the plan. Do I get it?
Yeah.
Okay.
So how does that work with being open and accountable for providers and individuals if we're using a tool that no one can see?
Dave, I guess I'd pose it back. Are you familiar with the tools that the MCOs are currently using?
Not really, and that's part of the problem.
Yeah.
No one knows what's being used.
Yeah, I mean, and with this one, it's we're able to standardize it, so all three MCOs are going to be using the same tool, and so we can compare and contrast that across all three to make sure that it's being applied the same, and to that I would say that this is a validated research-backed tool, so it's not something that's homegrown. From the state side of things, and we know that Aetna was using it previously, and when we did some preliminary looking at it, that there was actually some more services that people were eligible for based on the NRRAI than the other MCOs. But that's just some preliminary data, so I don't take that with a grain of salt.
Okay, so families and individuals have no way of preparing for this meeting that's going to determine their supports.
I would suggest they still prepare in the same way they always have been, is come be prepared to answer questions to the best of your ability on what what your goals are, what you hope to accomplish, and what those support needs are.
Question from Emily.
Hi, thank you. Just to kind of piggyback off what Dave said. So, in the current process, if we have an appeal, we would look at the basis assessment, very detailed to see what was information gathered there to be able to know kind of what to appeal. So with the MIFI or Inter-RAI, if we're not able to review that, how will the appeal process work, or how will we know what information was marked on those assessments if we don't see it?
Emily, are you referencing the MFEI or the service plan? Because if
Either, really.
yeah, yeah.
I
Well,
mean,
if it's
probably the inter-RAI more because I think we'll come across that more just with the funding piece versus just the eligibility piece. How will a service provider be able to appeal that process, I guess?
Well, I think it depends on what exactly they are appealing. Because right now, if you do the MFEI, or if, you had a tier change,
Right.
that's not appealable today.
Right, right. But we would be able to review to see what the discrepancies were between those assessments from year to year. And we're not going to have that ability anymore. Is that correct?
At least for the first year, but then, once you've got a few of these notched under your belt, you will be able to see those discrepancies from year to year.
Oh, we will. So we'll be able to review them and kind of compare each year.
Yeah, you should have the historical. You'll still be able to access the historical assessment from the previous year.
Oh, okay. Okay. I thought we weren't going to have access to that. Okay. Thank you.
No, the completed MFEI will still be provided to families and service providers to inform those that the support planning. So yeah, you'll be able to have that. I think even within your own records.
Great. Awesome. Thank you.
Tammy?
Okay, so I got confused again. So even though we'll have access to the MFEI, that's just determining eligibility. What determines funding tier, whatever we're calling it now, is the inter-I tool that we can't see, correct? We won't be able to see, we won't be able to dispute or say, dispute why the funding isn't adequate if we don't know how the funding was determined, because that is a tool that's proprietary that we cannot have access to. Am I getting it?
Well,
yeah.
I don't know the answer to those questions yet, because I think that's a little bit cart before the horse. So we're still that's something we're going to pivot to. Once we've gone live with the MFEI, we will be looking at what are the data elements for any acuity based rate. And so the focus will be on transparency and the process, the standardized way it's applied, and how those decisions are made. Not necessarily sharing all of the data points and the decision logic and the algorithm, but that's still stuff that we have to tackle with you all.
Okay, I'm trusting you to tackle it.
It'll be a nice clean tackle. No penalties.
Thanks.
Awesome. And while we wait for another question to come up, just a reminder to everyone on the call that we will have one more opportunity, one more webinar before go live date. So please stay tuned for for the last Thursday of the month of June, and invite others to attend that. That will be our last webinar prior to go live. Any other questions, please? And Cami?
I want to make sure no one else has a question. Is it mine? Is it me? Is it my turn? This is not really a question. It's just kind of a comment. And that is that presentation after presentation, webinar after webinar, document after document, I hear that, we're going to give people their preferred lifestyle, and there's going to be no disruption, and there's going to be choice and autonomy and all of that. But not really. So this is no indictment on anyone at KDADS or CMS or anything. I just think it's a fallacy in the whole final settings rule makeup, and that is, it really does take away choice. There's no disruption unless you lose your case manager. There's no disruption unless you can't continue, and you get your choice unless your choice is center-based work, and then you don't have that choice. So it's not entirely how it's built, and that makes me sad, and I don't understand it, and I have to accept it, and it's nobody's fault, I guess. But I'm just going to keep pointing it out, because I think at some point, final settings rule needs to be modified. Or we can't call it what we're calling it. We can't keep being disingenuous and saying it's about choice when it's not. Okay, that's it. My rant is over. Y'all are awesome. Nobody's fault. I trust you. I know you have everybody's best interest at heart. You're not evil. But there's a problem. Okay.
Yeah. I mean, you're highlighting some inherent tension, and I don't know that there's ever really a way to, resolve that tension.
Yeah.
And to go to chat, I want to make sure that we're not skipping over the questions we're getting there. A question came in, about how do we verify that the MCOs have captured the right information during service planning? And this was kind of an extension to that question by David there, to on whether the responses to the service planning process can be reviewed by families. But Seth, how would you answer that?
That's it's a very good question. I don't know that I have a super well-rounded answer for you, but I think, we again, it goes back to standardizing the training and making sure that those who are assessing it, whether it's a CDDO assessor doing the MFEI or MCO care coordinator applying the NRREI, you have to be trained and properly certified on how to apply those tools. And so that's where, we want to, from the state KDAD's perspective, want to make sure that we're monitoring that and that those individuals applying those assessments are adhering to that training. And so this is going to, in a perfect world, ensure that there's consistency in how those responses are recorded and interpreted. And again, that feeds back into another component of this is the review and oversight from the state and being able to review all of that data because it's now coming back to us. This is not something that we've had before. So that's one of the, I think, the key changes that can't be overstated. So we'll be able to review those assessments for accuracy, have all of the data, spot check for consistency between what's being reported, what's observed. And then when we get complaints or things of that nature, we can then go in and have that line of sight as well. And then, don't want to miss this either, but there's always those participant rights. Individuals and families have the right to review those results of the assessment and the decisions based on it. So if there is a disagreement, there is a formal appeal process to request that clarification or even challenge the outcome.
Mm-hmm. Thank you very much, Seth. And you did mention something there that I think definitely we can zero in more on the ability to QA the process now, which as of today didn't exist, but going forward with this process, we will be getting the data, and KDADS can now make sure that service plans are actually meet the proper quality standard. So that is very, very valuable to mention. Any questions based on that? Another question from the chat is, I think Noel did wanted to clarify that as the CDDO, they are going to be allowed to print a copy of the completed MFEI and provide it to the CSP or guardian.
Yeah, Robin, correct me if I'm wrong, but that's how it is right now with the basis in most CDDO areas, and that practice won't discontinue with the MFEI.
Yeah, I was just to add to that a little bit, I was just typing something out, but I mean, I'm looking at, it's part of the requirements for CSPs to have that in their records, like their master file, I always called it. And of course, guardians have the right to those records. So we would anticipate that practice continue. Yeah.
Thank you very much. Other questions that are in chat is, will the single rates just be for new participants coming onto the waiver for a year, or will the single rates continue?
No, the hope is, the intention is that it will just be a year, and we will have a more robust and equitable funding model after a year for everybody, regardless of you were under a legacy rate or under this new bridge rate.
Thank you, Seth. And another question is related to the inter-RAI. Who is providing the training or on administering the inter-RAI to the MCO care coordinators?
The MCOs are, I believe, working directly with inter-RAI. And there's, practice assessments and Bruce, correct me if I'm wrong, but isn't there even a certification process for them before they can roll it out? But we are meeting weekly with the MCOs on their implementation timeline now, and there's some phase milestones that need to be met there.
Definitely. And yes, just to the training we have, our CDDOs have modules on KS Train. They can go on there, take self-paced trainings and get certification. The MCOs can have access to those modules as well. However, the instruction to them is to go out there, contact inter-RAI directly, contact inter-RAI fellows that are subject matter experts to seek training for their care coordinators. So they have been given that that leeway to go ahead and seek training for their care coordinators on the tool, as done in other states where the MCOs currently operates the inter-RAI as well. Any other question? Okay, seeing no hands up or questions in chat. Seth, any final words for us before we bring this to closure today?
Just really appreciate y'all taking time out of your days to listen to us blather on. So more information to come.
Awesome. Thank you, Seth. And thank you everyone for attending today's webinar. We'll talk to you again at our open office hours and our monthly webinar for next month. Thank you all and have a wonderful day. Bye-bye.
Yeah, thanks, everyone.